the clinical manifestations in patients with the Cushing's. The earliest manifestation in Cushing's is weight gain, right? And this weight gain is what is responsible for, and mainly they'll have what is called central obesity. And this central obesity is the one which is responsible for the insulin resistance in the individual, and this insulin resistance is the one which makes the individual to develop type 2 diabetes mellitus. Okay, so that is the earliest manifestation of the Cushing's. Then followed by that, you need to know about the three important metabolisms. What will be the abnormalities in these three important metabolisms in Cushing's? So first is the glucose metabolism. So there will be hyperglycemia in these patients with the Cushing's. Why? Because if you see the basic physiology of the steroids, they cause the hepatic gluconeogenesis, or steroids, they increase, right? They increase the hepatic gluconeogenesis, right? And in Cushing's, more and more steroids are there. So more and more hepatic gluconeogenesis will be there. So as more and more hepatic gluconeogenesis occurs, so there will be hyperglycemia in patients with the Cushing's. Then coming to lipid metabolism. So what the steroids do to the lipids is, these steroids, they cause lipolysis, right? Where there will be breakdown of the lipids into the free fatty acids. So in patients with Cushing's, there is excessive lipolysis. Once there is excessive lipolysis, there will be excessive synthesis of the free fatty acids. And this excessive free fatty acids will undergo redistribution. This excess free fatty acids will come and accumulate within the face, where the individual will develop round face. The excess free fatty acids will accumulate in the nape of the neck, and that will result in what is called as the buffalo hump. And this excess free fatty acids will accumulate within the abdominal area, resulting in what is called as the central obesity. So these are the abnormalities regarding the lipid metabolism. All right. Next, coming to the protein metabolism. The basic physiology of the steroids on the proteins is, these steroids, they cause the proteolysis. So in patients with Cushing's, there is excessive protein breakdown, or there is excessive proteolysis, and thereby where are the proteins which are present in our body? Mostly that is within the skeletal muscle. So these patients, they will have excessive proteolysis within the skeletal muscles, resulting in the myopathy, right? And which myopathy is more common in patients with the Cushing's? It is the proximal myopathy that is more common. And because of this proximal myopathy, remember, these patients, they will have difficulty in getting up from sitting position, right? They have difficulty in getting up from sitting position, right? And the another important thing is, they have difficulty in climbing the stairs. Okay, so they have difficulty in getting up from squatting position, and they have difficulty in climbing the stairs. So that is because of your myopathy, right? Then followed by that, this excess glucocorticoid secretion, whichever is occurring in Cushing's, it overcomes, right? It overcomes the ability of, right? It overcomes the ability of 11 beta HSD2 to rapidly inactivate the cortisol to corticosterone. Okay, so what happens is, in the physiological levels of the steroids, if they are present, they are rapidly inactivated by this substance called 11 beta HSD2. They are rapidly inactivated from cortisol to corticosterone. But when there is excessive glucocorticoid secretion, then what happens is, this 11 beta HSD2, they cannot inactivate the cortisol to corticosterone. Usually, where will this inactivation occurs? This occurs within the kidney. But when there is excess glucocorticoid secretion, this inactivation of cortisol to corticosterone within the kidney does not occur. Now, thereby what will happen? There is excessive cortisol production. This excessive cortisol will exert the mineralocorticoid action. What will be that mineralocorticoid action? That will be sodium and water retention. So because of sodium and water retention, these patients, they develop the diastolic hypertension and they will cause potassium excretion resulting in the hypokalemia. And because of excessive sodium and water retention, there will be also development of the edema. And there is also excessive H plus ion excretion, and because of excessive H plus ion excretion, that will result in metabolic alkalosis. Okay, so these will be the manifestations because of excessive mineralocorticoid action. So in patients with Cushing's, they also have the mineralocorticoid activity. Why is that? Because this excess glucocorticoid secretion, it overcomes the ability of 11 beta HSD2 to rapidly inactivate the cortisol to corticosterone. So that ability will not be there. So thereby the cortisol will have the mineralocorticoid action by stimulating the epithelial sodium channels which are present on the principal cells of the kidney, right? Then the another important point you need to know is that whenever there is excessive glucocorticoid secretion, that also interfere with the central regulatory system. What is that central regulatory system? That is in the pituitary. So this excess glucocorticoid secretion will also inhibit or will also interfere the central regulatory systems, right? By interfering the central regulatory systems, that will lead to suppression of the gonadotrophins. Okay, because of the suppression of the gonadotrophins, that will result in what is called as hypogonadism. That will result in the development of amenorrhea. So there is hypogonadism and as well as amenorrhea. That is because of the suppression of the gonadotrophins from the anterior pituitary. That means there will be decrease in the FSH and at the same time there will be also decrease in the LH. Not only that, there will be also suppression of the hypothalamo-pituitary thyroid axis. So thereby, there will be decrease in the TSH and that will result in the hypothyroidism. Right? That will result in the hypothyroidism. So remember, the excess glucocorticoid will not only will have the Cushing's manifestation, will also have mineralocorticoid activity, will also have the hypogonadism, will also have the hypothyroidism as well.